screen and get that up for us. Um, so today we're going to talk, and I assume everyone can see this. We're going to talk about the ABCs of prostate health. If you have questions, you can just stop and ask me. It's meant to be informal. And again, thank you for for Larry and Bella for this opportunity to speak to the Troy Rotary Club. As you know, I'm a professor at Oakland. I oversee robotic surgery for Beaumont Health. I also do clinical research in oncology for the Michigan Institute of Urology. Today, I kind of broke up the talk into three areas. One, we'll just talk about prostate anatomy, the key prostate health issues for men, and a little bit about prostate cancer. I know that I see a lot of women on the call as well. I think it's important, as Larry alluded to, men are terrible patients. They don't ask questions, and because of that, they're poor healthcare consumers. And they just, you ask a man how you're doing, he says fine, and he just heads for the door. And then you look at the wife and you find out the partner, and you look out and you find the real story of what's going on. So it's great to see women, because women are actually the bigger advocates for men's health than the men themselves. With that being said, let's just focus on the prostate anatomy. We're not going to go into huge detail, but the question is, what does the prostate do? You can see here the prostate lives right below the bladder. Okay, here's your bladder, and here's the prostate. And it basically makes up a man's ejaculate. The only use we have for a prostate is it prepares the sperm for fertilization. So after childbearing years, you really don't need a prostate. The problem is that the prostate sits below the bladder, and it's where the urine passes. It's how a man urinates through. Or it's another way to look at it, it's the donut, which a man urinates through the donut, and that's the prostate. And as men age, that donut gets a little bit bigger and bigger, and it becomes more difficult for a man to urinate. So the prostate has a significant impact on men. If you look at it and you want to separate cancer from BPH or just an enlarged prostate, but you can see these numbers, 230,000 new cases of prostate cancer are diagnosed each year in this country. It's the second leading cause of cancer death in the United States in men. But the good news is it's typically very treatable. Men do very well, and I'll highlight that a little bit later. What I'm also going to talk about is BPH, which is much more common. 90% of the men by age 85 have an enlarged prostate, and it's very common disease that we see every day. If you live long enough, you're going to have enlarged prostate issues. The other thing that comes up with BPH is erectile dysfunction. 30 million men have ED or erectile dysfunction, and that's a lot of men. So it's very common. 50% of the men ages 40 to 70 have problems with erections, and I'm also going to talk about that today. Again, at a high level, just give you a flavor, a taste of how we think about the disease and what are the available treatment options. With that being said, the key prostate health issues for men can be basically broken down into 4 parts. Well, the first part is the enlarged prostate. That's just a result of aging. As men get older, their prostate will grow. Younger men can develop something called prostatitis, which is an infection of the prostate. I'll touch a little bit on that. We'll talk about erectile dysfunction. And then lastly, we'll talk a high level about prostate cancer and how we diagnose it, and what are kind of the newer treatments or how we deal with it. And as I said before, women play an important role in the identification of men's health issues. They, again, are the advocate. They are the ones that make the men go to the urologist, go to their doctors. And it's very important that women have a good understanding of men's health issues, because they play a significant role in the treatment of men. So let's just talk about BPH. Again, most common disease we see with prostates in men in this country. And basically it's an enlarged, non-cancerous, it's not cancer, but it's an enlargement of the prostate. And I go back to that donut analogy that I told you earlier. I explain the prostate as a donut that essentially surrounds the urethra. And as men age, that donut grows, and what you see is a narrowing, or the whole of the donut becomes much smaller. I mean, this isn't brain surgery. This is essentially plumbing 101. So men, as they age, are trying to urinate through a smaller opening or a smaller tract. Because they have a smaller tract or the outflow is obstructed, they have difficulty in voiding. They have increased frequency, a weak stream. They stop and start when they urinate. They may have urgency where, before they could wait to the next exit sign or wait to a commercial, and they can no longer wait. They have to run to the bathroom. Very commonly, they'll get up to urinate at night. It's normal as men age to get up once or twice a night, but I'll see patients in my office that will get up to go to the bathroom 3, 4, 5 times a night. And obviously that can be a major detriment to your overall quality of life. The risk factors are pretty much age. As men age, they will develop this disease. It's just a matter of the severity of their disease. Obesity and sedentary lifestyle are also risk factors, but it's mostly age. The other thing that we'll touch on, but not go into big detail, is as the prostate grows, you will see an increase in the PSA. PSA is a blood test that we use, prostate-specific antigen, to screen for prostate cancer. So the PSA usually goes up when the prostate's enlarged. Doesn't always mean that the patient has prostate cancer present. So here's another picture, and here's a normal prostate, okay? And then as the prostate grows, you can see that this channel becomes narrow. So it becomes harder and harder for the man to empty his prostate. And what happens is the bladder muscle gets thickened because it's working harder through the small channel to get the urine out. And that can lead to many problems because it can lead to stagnant or stasis of urine in the bladder. So men sometimes get infections. If it gets very bad, it can also lead to pressure onto the kidney, so it can lead to kidney damage. Or in very severe cases, if the channel gets too tight, a man can't urinate, and we call that urinary retention. So that's why it's very important that we treat this disease so we don't end up with infections, kidney damage, or the inability to urinate at all. So let's talk a little bit about treatments. Again, 50% of men over age 50 have BPH, very, very common. And most of the treatments can fall in 2 categories. There's medications, which I'll talk about, and surgical treatments, which I'll highlight. And these surgical treatments can be in the office or typically in an outpatient setting. Here are the medicines. These are pretty common medicines that we use on a daily basis. You may or may not be taking it or heard of it. Your husband, brother, I don't know, father may have taken it, but there's a medicine called Flomax, Avodart, Jalin, Cialis, or Rapaflo. And basically the medicines open up that channel so that the patient can empty his bladder better. That's one class of drugs. And then the other class of drugs is like Avodart, are drugs that will shrink the size of the prostate. And so we will make the prostate smaller. Again, going back to the donut analogy, open up that tract so a patient can urinate much better. The advantages of medicine is it's no surgery, and it provides typically symptomatic relief. They work very well. The disadvantages of the medicines is they're not cures. You have to take these pills for life. And they're like any medicine, there's always potential side effects. It can affect sexual drive. It can affect erection problems, ejaculation problems, dizziness, or lack of energy. And unfortunately, medicine in our current health environment can be very expensive depending on coverage. So there is good and bad with the medicines. They work very well, but they also have side effects and sometimes can be very costly. If medicines don't work, or if medicines are ineffective, or a patient wants to move to more of a definitive or curative intent, we would consider procedures. And there's 2 basic procedures that we use. This is the kind of the gold standard is called the TURP. You may have heard of this as the Roto-Rooter, where we literally, again, sorry about this, keep going back to the donut, is that we would use a green light or a shaving mechanism, and I'll show you some videos where we'll just open up that channel or open up that donut hole so a man can urinate better. The advantages are they work great. They're great procedures. They've been around for a long time. They remove the prostate tissue and usually can resolve the symptoms that patients suffer with an enlarged prostate. The disadvantages are obvious. It does require a procedure. It's a hospital-based procedure. Typically, you need a catheter after the procedure. You have to restrict activity. And there can be occasionally post-op problems with sexual dysfunction, bleeding, incontinence, or stricture. Even these are potential problems, usually rare, but things that you need to be aware of. I'm just going to pause for a second. Any questions? All right, good. So we'll just keep going. Here's a video that will explain. On one side is going to be the TURP, where we shave the prostate. Don't worry, it's not going to be bloody or gory. And the other side is the laser. And you can kind of just get a flavor of how these procedures work. So on the left panel, you can see that that's a TURP, and we're literally shaving open the prostate. And in this black part is the bladder up here. And this is literally a prostate that we're opening up and trying to make that donut hole bigger. On the right side is the laser. This is one of our newer procedures where we will actually laser open that prostate or laser open that donut hole, and that will get a man to urinate. Like I said, this isn't brain surgery. This isn't, physics. This is just plumbing 101, where we're trying to open up that channel and so a patient can urinate much better. But that kind of gives you a taste of how we do this, whether we shave it or whether we do the laser to open it. We're just trying to open the pipe, so to speak, or open the outflow so a man can empty his bladder better.
Doctor, a quick question. What is the size of the opening that you're trying to achieve?
Normal size is about 8 French, so that's about 2 or 3 centimeters, and we try to maximize that to a double or triple that number. So it's about normally 8 French, but that it can distend to it's normally 2 to 3 centimeters, but you can distend it or open it up pretty significantly, triple or quadruple that size.
Thank you.
So here's one of our newer treatments, and it's called the UroLift. And this came out about 4 years ago. I was the first in Michigan to use this, and it uses these, again, bladder, prostate, but it uses these tacks to open up that channel. The nice thing about this is that this procedure is very quick. It takes about 5 or 10 minutes. We can do a very light anesthetic. It preserves sexual function, and it's pretty well tolerated. It's about 70% effective. We've had very good results with it. And it's a nice, easier first step procedure that doesn't require a lot of energy into the prostate. Patients do quite well. And this is how it works. Basically, we go in, like you saw in that video, with a camera while patient's asleep, and we put in these tacks that will anchor on the outside of the prostate, and then they will kind of squish the prostate or open up the center channel. And we have a device that can kind of just tack this open. Or another analogy I like, it's like pulling the drapes open. With the prostate closed, sometimes if we pull the drapes open, it can allow that tract to open up better and the man can urinate better. So this is the UroLift. It's a permanent implantation, very well tolerated, 70% efficacy, minimal risk. And it's a nice new procedure it's been getting a lot of traction over the last couple of years. It's only been out about 4 years. We don't have long-term data just because it's so new, but in the short term, it looks it's doing a good job. When you look at it inside, this is pictures of one of my patients where this is the prostate. So we're looking through the penis, the bladder would be going into the screen. This is that center channel that I'm talking about. And these are the lobes of the prostate on each side, left and right. And you can see it's going to be very hard for a man to urinate through this. We put in these tacks. I put in 2 tacks on each side, 2 UroLift implantations. And this black hole is where the bladder is. And you can see how, again, it's going to be much easier for a man to urinate because this tract is wide open. The urine will flow much better. It will help with his frequency, urgency, decrease force of stream, getting up at night. And you can just see, you don't have to be a doctor to see how this works. And this is the Urolift implantation. Again, opens up that blockage. So let's switch gears and talk a little bit about another common prostate issue is prostatitis. Typically, we see this in men under 50, the 30 to 40-year-old crowd, and it's an infection or inflammation of the prostate gland. Typically, it's associated with pain. Men will describe pubic pain, pelvic pain, burning when they urinate, things like that. Typically, we can diagnose it based on history, but sometimes we'll check a urine test. And the nice thing about it is prostatitis usually responds very well to antibiotics. We'll typically use a 2 to 3 week course of antibiotics. Once we treat the prostatitis, the symptoms usually resolve and patients do quite well. Now I'm going to focus a little bit on erectile dysfunction. Again, related to the prostate directly or indirectly, it's a matter of debate, but erectile dysfunction is commonly associated with an enlarged prostate. And it's the inability to achieve and or maintain an erection sufficient for satisfactory sexual activity. You can see it's a very vague definition, but a very common problem. Again, 50% of men aged 40 to 70 have problems with erectile dysfunction. The diagnosis is easy. You know, we have questionnaires, but you know, if you can get a male patient to talk and talk about, you know, such a sensitive issue, you can pretty much diagnose it in a couple of questions. And the nice thing is we have a lot of great treatment options to help men and couples with this problem that is so very common. The most common treatment is the medications. We all see the commercials. We know about, you know, the 2 bathtubs, the Viagra, Cialis. And the nice thing about these medicines is they work very well. They've been around for almost 20 years. They're very safe. You take it typically 1 hour before sexual activity, and it improves the response to sexual stimulation. It's not an instant erection. You still have to be stimulated. It doesn't, again, that doesn't give you that automatic erection or the 4-hour erection that they talk about in the commercials. We rarely, if ever, see that. And it can help achieve a good erection with reduced risk of developing that 4-hour erection. Again, we rarely, if ever, see that problem. Usually when we see the 4-hour extended erections, it's usually men are taking other drugs, you know, legal drugs, and that they usually show up in the emergency room. So rarely, if ever, we see it in patients who aren't taking illegal drugs. Side effects are real, though. That, you know, like any medicine, there's always potential side effects. A common side effect is flushing. You know, men will complain that they're facial flushing. They'll get headaches, you know, because you get increased blood flow to the penis, but you also, one of the side effects is get increased blood flow to the head. Sometimes men will complain of muscle aches, especially with Cialis. We see that a lot. Nasal congestion, again, increased blood flow in the head, sometimes can cause nasal congestion. Like any medicine, it can cause some GI distress, you know, some upset stomachs. Usually it's temporary, not a big deal, goes away. And very rarely, you know, this got a lot of press, is the vision disturbances. We rarely, if ever, see that, but it can happen. Sometimes guys taking Viagra will complain of this blue hue. Things will look blue. It's temporary, typically goes away. No real long-term sequelae of taking these medicines. Overall, they're very safe. I'm just going to talk about injection therapy. I don't mean to freak out people or men on the line, but I think it's important that people understand it. One of the things that you have to realize is that the pills don't always work. And I get a lot of men who get frustrated because they assume they take the pill, it's going to work. But what the commercials don't say, as you start getting into your 70s, the pills aren't meant to work. They're really good in the 50s and 60s, but as men get older and are still sexually active, even in their 80s, which is very common, we have to switch to injection therapy. And it's always the ouch, you know, the shock value of seeing this picture. But these medicines work very well. And once we teach and train, it can be easily self-administered. If a man wants to be sexually active, he'll literally inject the base of his penis, like the picture. They work great. It's relatively inexpensive. These medicines are 50, 60 bucks. So not cheap, but affordable. Obviously, anything has side effects. There's fibrosis, scarring, or it can have long-lasting, again, pretty rare painful erections. this is the next step after the pills don't work, is if a man is interested or a couple's interested, we'll go to injection therapy. Another treatment is implants, penile prosthesis. There's two types. There's the malleable implant and then the inflatable penile prosthesis. The malleable is just what you see. It's kind of the Gumby, you know, remember the old Gumby dolls, where we implant these devices in the penis. And if a man wants to be sexually active, you literally just bend the penis and can get a reasonable erection. So it's pretty well tolerated. It's an option. Again, I'm not here to freak you guys out. This is, you know, a lunchtime talk, but I'm just going to just keep it at a high level. Another option is, this is kind of the Cadillac of penile implants, is the inflatable penile implant. And the way these work, these are kind of cool, is that there's a device placed in a man's scrotum, and what the man will do before sexual activity is literally squeeze it like the shoes that we used to have, where you'll pump up the penis and you can get a very good erection. These are great because you can't tell if patients have these, so there's no this embarrassment factor. Everything's hidden, or it's inside, so if you're at the gym, no one will know you have this. Wearing a pair of pants, it gets pretty flaccid, so it's not obvious. And a lot of guys like this because, you know, the pills and the shots don't always work. This will always work. So it gives you that confidence that you'll be able to perform, and it kind of restores some spontaneity. A lot of problems with the pills and the medicines are, you gotta kind of plan to have sex. You gotta take it an hour before, you know, pray that it works, you know, blah, blah, blah. With this, you know, you get your spontaneity back, and you can use it, you know, when you know, you just literally pump up your penis and it will give you a good erection with good performance. I'm going to pause here. Any questions about erectile dysfunction?
Quick question for you. So on these devices that they're using to get an erection, how does that impact their ability to have an orgasm? I mean, are they two separate things, or?
Yeah, no, that's a great question. Erection, ejaculation, and orgasm, even though they seem like they're one process, are three separate processes. They just happen to occur in the obvious order. It won't improve the orgasm. Okay, we can get, basically the treatments I showed you is just to get the penis hard, but it won't affect orgasm. We don't really have any good treatments for orgasm. We don't have medicine or treatments to improve the quality of the orgasm. Sometimes we may check a man's testosterone. If they have low testosterone, we improve their testosterone and may improve the quality of their orgasm, but we honestly don't have really good treatments for that. And as men age, the quality of the orgasm, the quality of the ejaculate will go down. Here, the current treatments are really just focused on improving the quality of the erection.
I have a question. I understand how you can pump up the prosthesis, but how do you deflate it?
Yeah, that's a great question. What we teach the patients is that if you bend the penis, there's some valve, and I don't know the physics, but if you bend the penis after you're done, the fluid will go back out into this reservoir. So you just literally bend the penis, it's not painful at all, and that will release the fluid back away, and the penis will become flaccid. It works very well, actually.
So on that, I always heard that once it's erect, if it's bent, that's painful. But is it not painful?
No, no, that's a great question. What you're asking about is another disease called Peyronie's disease. Totally different silo or different process. And Peyronie's disease, we see it in about 3% of the population. And that's where men may have a crooked or a bent erection. They can't get a straight erection. And that is totally separate, where people will develop that from scar tissue. From just normal sexual activity, you develop a little trauma to the penis. but men with Peyronie, for some reason, develop abnormal scar tissue, and that can cause the penis to literally be bent. So different process, different issue. But sometimes if the Peyronie's is pretty severe, if they have a crooked penis or a bent penis where they can't penetrate, we would sometimes put these in to straighten out the penis.
هنا هي بتروح انا لعنده يراوز عنده هاي بيشتغل.
Okay, so we'll just keep moving on. So what I want to talk about, and I just have a few more slides and then we can, open up again for questions, is prostate cancer. As I said, prostate cancer is very common. It's the most common cancer diagnosed in men. I'm sure most of you know somebody or a family member or a friend of a friend who has it. It's 1 in 7 men will be diagnosed with prostate cancer in the lifetime. It's more common than breast cancer. And the way that we detect prostate cancer is through a blood test called PSA, prostate-specific antigen, as well as through a digital rectal exam or rectal exam. And then I'll show you, then we typically, if they have an abnormal PSA or abnormal digital rectal exam, we would diagnose it with a prostate biopsy. There's really no early warning signs or symptoms of prostate cancer. There's nothing to look for or to check for. It's really seeing your primary care doctor, getting your PSA checked at least on an annual basis, and having that prostate exam either by a urologist or a primary care doctor. The risk factors are very clear. As men get older, age is a factor. Family history, prostate cancer does definitely run in families. Men who have a first-degree relative with prostate cancer are 2.4 times at increased risk for developing prostate cancer. Race is a huge factor. African-American males are at increased risk for prostate cancer. They present at a higher stage and a higher grade. So we don't know why, but we know it's pretty consistent that African-Americans are at increased risk. Then the obvious stuff, smoking, obesity, these are less strong risk factors. Sedentary lifestyle can also increase risk for prostate cancer. And what's also interesting, and we've seen this in recent research that we've done actually in Detroit, we see increased risk in veterans, men who've been exposed to Agent Orange during Vietnam. And then we're seeing an increased risk in firemen and policemen because of their exposure to toxic chemicals. So the first responders we do see increased risk for prostate cancer. And through a foundation that we've set up, on a side note, we've been working with the local fire departments to increase awareness and make sure that our firemen and policemen are getting checked and doing what's recommended, something we've set up here in Detroit. So these are the risk factors, very common. It's typically diagnosed through a rectal biopsy, prostate biopsy. So the way this works, we do this in the office. Yeah, it's not as bad as it seems. I've never had one, but I do this every day. We basically place a small probe in the rectum, which is an ultrasound probe, so we can see the prostate. Here's the prostate from a side view. And then we can numb up the prostate, so we can freeze or put in a local anesthetic right into the prostate. And we can take samples of the prostate, and that way is how we diagnose prostate cancer. Doesn't look like much fun, but no one wants to do this. But afterwards, guys will say, yeah, wasn't so bad, but I don't want to do it again. So it looks worse than it is. And then what's confusing and where it gets tricky is that not all prostate cancers are equal. And this is where patients struggle, families struggle. There's a whole spectrum of prostate cancer from good to bad. And the way we determine good and bad is something called the Gleason scale. And it's basically a scoring system. We score the cancers. 6 is the best, 10 is the worst. And we use this 2-number system to determine whether we need to treat these patients or not. And one of the things that's changed over the last few years is that we've identified a lot of prostate cancers that don't require treatment that we can follow. Okay, so we've kind of gone from treat everybody, and the pendulum swinging back to where we just treat the ones that absolutely need to be treated. So with that being said, the treatment options are varied. And like I just told you, not all prostate cancers require treatment. And we kind of have to work through this with the family, with the patient on which need treatment and which don't need treatment where we can follow. With that being said, these are the typical treatments that we offer. If it's a low-grade, non-aggressive prostate cancer, we'll do active surveillance. If it's a little more aggressive, we may consider radiation. We can do seeds at Beaumont. We have a proton beam. We have a variety of different ways to deliver the radiation. What I specialize in is surgery for the prostate. So the robotic prostatectomy is a very common procedure. And then we have something called cryotherapy or targeted therapy, where we'll just freeze one part of the prostate. And then this is being used less and less. Sometimes, usually we use it in combination with radiation as hormone therapy. And then if it's very severe, we'll offer, we have a lot of other options to treat if the prostate cancer is spread outside the prostate. There's been, in the last 5 years, we've had 7 new drugs approved. We have 40 drugs in phase 3 testing right now. So the treatments for prostate cancer are very good. Patients tend to do very well. It's a very treatable cancer. What I tell patients in my office, it sounds weird, but if you had to get a cancer, this is one you don't mind getting because, again, treatment options are very good. Patients do very well. So it's not like pancreatic or lung cancer where, you know, it can be challenging still. With prostate cancer, we can do a very good job and controlling the disease or curing the patient. That's the end of my slides. That was like a high level, you know, warp speed, light speed explanation of prostate disease, kind of the ABCs of prostate health. I want to thank Larry for this opportunity, and it's a pleasure working and treating you, as well as Bella, the president. Thank you very much for this opportunity. I, you know, can open the floor back up to any questions or comments.
Dr. Jason, I have a question. Thank you very much. Great presentation. I don't know if I want to have sex or a donut. The question is something I've been interested in. Something I've been interested in for a long time is why men are, compared to women, of course, why are men less interested in their own health? Why are they terrible patients? Why don't they ask questions? What's wrong with us?
You know, it's a good question, and we've set up, the Michigan Institute of Urology set up a non-for-profit foundation actually to raise awareness for men's health. We do an event at Ford Field every year where we'll screen 7,000 patients. We have a Father's Day run to raise awareness. But that data is very interesting because when they study men and how they go to the doctor's office, the average time a doctor spends with a man compared to women is half. Men don't ask questions. They don't research. They don't look into their diseases. And they literally spend half the time in a physician's office than a woman when they're in front of a doctor. Well, unfortunate part of that, if you look at every major disease, you know, heart disease, you know, cardiovascular disease, stroke, men, and most cancers, men do not live as long. They, and in some cases, it's 4 times less compared to women. You know, the question is why? I don't know, and it's frustrating. I think there's a lot of just this maleness, you know, got to be tough, got to be strong, this denial that men just is inherent within men. You know, if a woman has a health problem or medical problem, she'll call her mother, her sister, her neighbor, and, you know, within an hour, she's figured out the whole issue. A male gets diagnosed with something, they don't tell anyone. They keep it inside, you know, and they don't ask questions. They don't call their dad or their brother who may have the same disease. It's just, it's a very strange psychology, but very consistent, and something that we've tried as a foundation to address and just raise that awareness to make men better healthcare advocates for themselves.
Thank you.
Doctor, can you hear me?
Yeah, go ahead.
Curious what you think about 5-10 years down the road with in terms of treatments for, say, prostate cancer. Do you see things changing much?
Yeah, I think definitely. What's really hot right now is this area called genomics, where we'll take the tumors and sequence the DNA and we can identify specific mutations where we can identify what's the best treatment. So now we kind of put everyone in the same buckets, and you got this disease, everyone's treated the same. And we've just started these treatments where we'll sequence the tumor based on the mutations of the genetics of that patient's tumor will dictate how we treat that patient. So instead of using this kind of shotgun approach, we'll use true personalized precision medicine to treat each disease based on the genetics of the tumor. So that's gonna continue to grow. We've already started it. There was 2 drugs approved based on the genetics of the cancer. So we already have therapies involved in that. And if you look at the drugs coming, it's all going to be based on these mutations. I think surgically what we'll see is more precise treatments, as far as ablative treatments, where we'll just treat the tumor itself. We'll either freeze it, laser it, and I think we're going to be taking out less and less prostate. So I think that the overline is we're going to be much more precise in the therapies we use and much more precise in the surgical interventions.
Very good. Thank you. With that, unless there's any other pressing question, I just want to thank you again for joining us today. Very informative, very factual. I mean, maybe too much for some. I don't know, but it was very, very good. I thought so. Does anybody have a final comment? Otherwise, we'll let Dr. probably
This is Dr. Gupta. I just joined. I was just in a medical CME meeting. It's a great program. A lot of men, I have noticed that, even including my brother-in-law, they see so many doctors, but they forget about the prostate doctor. They just get a prescription from the Flomax, but they don't actually see them. So it's very important to follow with the urologist. I see my urologist, unfortunately, he has moved out of town now, but it's nice talk. Thank you.
Thank you very much, Dr. Gupta.
All right. Well, Dr. Hafron, thank you so much. We appreciate it. And you're certainly welcome to stay on for the rest of the meeting, but you might have some pressing issues. I don't know.
Yeah, I gotta stop sharing this. No, I'm gonna jump off, but I'm gonna stop the share so I can give you back control.
All right.
Thank you, Larry. Appreciate it. See you soon, guys. Thank you very much.
Hopefully not too soon.
Yeah.
All right, so that concludes our main speaker program for this morning. And